Hi, welcome to tonight's webinar, Silver Fluoride, a New Era of Caries Management. I'm Dr. Jared Johnson, and I'm excited that you're here to spend this evening with me. We're going to cover a lot of the silver products that are on the market in the USA tonight and what differences are. And I'm just really excited that you take the time. This definitely has a place in dentistry, and there's a right way to do it in a way that it will kind of make you disappointed. And hopefully we can cover some of the things that you've been disappointed with in the past and how there are some newer products that can help you remedy those frustrations. I do have a disclosure to make here. I am receiving an honorarium for speaking tonight from SDI USA, and they have supported this lecture. It's an opportunity for you to learn. When we look back at the silver nitrate, this was first offered back as house solution. And this was really one of the first products here available in the United States. And if you look back at the first textbook on pediatric dentistry, here you can see nitrate of silver, preferably house solution, has a limited use, very shallow cavities. But too great dependence must not be placed upon it. Cavities treated with it are best only temporarily immune to caries. And we have seen this product and we've learned a lot about how to use silver products. And I'm excited to share them with you today and how we can maybe use it on something that's a little bit deeper and have a better outcome than Dr. Jordan had. The uses of SDF, or silver diamond fluoride, and silver fluoride have been linked back in history for a long period of time. We know that the silver and the fluoride are recognized to have a benefit. Silver works on the bacteria that are in the tooth, and the fluoride helps strengthen it. We're all familiar with the fluoride varnish. The only downside to this is it does cause a black distaining or discoloration. And this comes from the silver forming a silver oxide, which turns tooth black over time. After you apply this, it usually will happen within the first 4 hours. And we must take note that silver diamine fluoride will only stain demineralized areas of the tooth. So my word of caution to this is if you're treating a tooth in the anterior region, you're going to need to apply a barrier or something to any other teeth in the region that have demineralized areas to avoid coming with a black stain. So keep that in mind as we move forward. It's not a fun situation to have someone come back to your office with a tooth that's discolored and it wasn't the tooth you treated. If we look at some of the commercially available products here in the United States with the silver nitrate, there are different solutions of this. 25% has been the most commonly one used. You can look at, we have a Advantage Arrest silver diamine fluoride. Recently, within the past few years, we've had Riva Star come on the market. And I was reading about this product when it came out, and it turned out I wasn't using it correctly. And I think part of the community and things that need to go through this are answered by the Riva Star Aqua, which just came out this year. And it solves a lot of the problems that you may have been having in your office with the Riva Star of burning soft tissue. And me as a pediatric dentist, that's a big concern. It's great for rubber dam isolation and indirect pulp therapy, but now we have another product that can be used in either a single step or a two-step to benefit pediatric patients as well. Contraindications to SDF are heavy metal allergies, presence of severe soft tissue inflammation, someone that may not have been to the dentist in a while and has a lot of tartar. I'd recommend you start off going back to the basics and do your hygiene control and debridement prior to getting things done unless there's an urgent problem. Pregnant or lactating women, and adverse reactions are very rare. Probably the most common one would be us staining a child from getting it on their skin. It would be the most common thing that's happened at my office. But to date, I haven't had any allergic reactions to the product. Like I said, the original Riva Star, if it comes into contact with any soft tissue, you will get a burn of the soft tissue. So you need to use a gingival barrier or a rubber dam. Riva Star Aqua is a new silver fluoride treatment, and it eliminates that soft tissue irritation and need for a barrier. It can be used in a single step alone or as a two-step product to reduce staining, and we'll cover some of the differences in the two-step versus the one-step today. The silver diamine fluoride products are covered for treatment of dentin hypersensitivity. This is just as fluoride varnishes. We don't have them approved yet for a caries arrest. I'm sure that will be coming here as we have multiple studies that are ongoing to increase evidence. If you're using it in kids like I am, it is off-label. It is only for people over the age of 21. If you look at contraindications to potassium iodide, iodine allergy. So if we look at our basic knowledge from physiology, there's two different types of iodine. We have like the provenance iodine, and then we have elemental iodine. So if we look at what we're using in our water lines, thyroid uses, a lot of those products are elemental iodide. So people can't really have an allergy to that. If they have like a betadine or the provenance iodine, they could have an allergy to that. So that would be a contraindication. Pregnancy and breastfeeding are also listed on the UCSF form, but I would just ask your patients, if you have a concern, be safe, use just step one. The procedure for Rivastar is a patented two-step procedure and minimizes the risk of staining. When you apply the potassium iodide solution, the silver binds with the iodide, and it makes it so the tooth does not discolor as much. And this results in a more aesthetic outcome for your patients. Recently, we've had the new edition of the Rivastar Aqua, and we've had one study to help show that the silver fluoride and the silver diamine fluoride, both these products is the same, and both of them, when you use two steps, need to behave in a similar manner. Here's a list. I'm going to go through these with actually all the products that we have out on the market today. If you want to take a picture of this, go ahead, but we're going to work through this. When we look at caries arrest, originally the silver nitrate, that in conjunction with a 5% fluoride varnish, sodium fluoride varnish, will be approved. It will arrest decay. It's been studied. You can see Advantage Arrest will do so as well. And the Rivastar and the Rivastar Aqua, the silver fluoride in them has shown to arrest caries. If you look at all these products as the sensitor, it's the same manner that we just talked about. The silver nitrate, if you combine it with 5% sodium fluoride, will provide sensitivity relief. The other three products will also do the same as their own, as the silver occludes the dentin tooth and the fluoride penetrates into the tooth, making it less susceptible to demineralization and sensitivity. A big one here is reduced staining. There's a lot of people that won't use SDF on the anterior teeth. Here, I'll show you this video at my office, but I did a time-lapse video because I couldn't figure out why I wasn't using the Rivastar correctly. And the silver nitrate and the Advantage will definitely stain the teeth black. This is a time-lapse video 48 hours after we had the tooth that was extracted treated. You can see less staining on the side of the Rivastar and more staining on the side of a traditional SDF. You skip the second step, you will end up with this, and we can talk about the differences in arrest rates here in a little bit when we review the literature, but you'll have the same thing with the Rivastar Aqua. It'll behave the same as the Rivastar without the adverse tissue reaction that you're seeing from the Rivastar if you don't have a gingival area. Biofilm penetration, all these products are going to inhibit bacteria, and they're going to be great with the silver acting on the different parts bacteria uses to grow, and then the fluoride is going to actually interact with the tooth. So that will provide you with the fluoroapatite, which is 10 times less likely to have an acidic attack than using just a regular product on the market. Antimicrobial, all these products do affect the microbes. I'll show you some images here of how SDF has an inhibition layer. If we look at bond strength to glass ionomer, I'm going to touch on composite bond strength later. Silver nitrate, there's no study comparing that. I think that's just because we don't have a lot of people using that right now, because we have the alternatives of the Advantage Arrest and the Rivastar. Advantage Arrest will increase bond strength, but you have to wait a week after applying it and use a glass ionomer container. The Rivastar will immediately increase the bond strength of the glass ionomer if it's rinsed away. So that's one advantage of using one product versus waiting for the other. A disadvantage of the original Rivastar was that it had to be refrigerated, and that can be difficult. Maybe your office doesn't have a fridge that's specific for patient occasions and dental materials. And it's nice that the next step of Rivastar does not require refrigeration. The Rivastar Aqua, Advantage Arrest, and silver nitrate don't require refrigeration. This is a new advantage too. Rubber dam isolation need to be required. I had a kid where I thought I was going to be able to have an aesthetic outcome, and he was not very cooperative. And when we went knee to knees, one of my first patients I treated with Rivastar, and he had a lot of soft tissue discomfort and turning white, and it just was not a great experience because I was not reading the label on the product to use a correct isolation. So you're not going to have that with any of these other three products, especially this new development of the Rivastar Aqua. Ammonia is also not present in the Rivastar Aqua. So you're not going to have an odor or smell. You'll still have the silver diamine fluoride. It's in the other two products here, and it's not in silver nitrate. You can practice great dentistry with all these. Whatever is going to work best in your hands is what I'd recommend that you choose. And it really depends also down to what your patients want. Not everyone wants to have a dark stain on their tooth, especially one of their front teeth when their kids are starting school. It may be a benefit to them as a patient going through things, but also we got to look at what's going to be best for their outcome, for their mental health, and carrying on with other people in their class. If we look at pHs, we're going to have a basic pH for the Advantage Rest and the Rivastar. Rivastar is going to have the highest pH, and then silver nitrate depends on the concentration. We will see different pHs, so it's more acidic. So the higher the concentration of silver nitrate, the less acidic it is. The only product on the market that's been touted to be a physiologic pH is the Rivastar Aqua. When I got this product to test at my office, I used a litmus strip, and it was from a 7 to 8. I don't have any data from SDI to tell you the exact pH, but that is what I found with that home litmus strip test that you can get on Amazon. If we look at formula comparison, so the Riva Step 1, and this is going to be a silver fluoride. So it's actually got more fluoride in it, a higher concentration than Advantages. And that's mainly the reason for the difference in cost. So when we go back to high school chemistry and do calculations, you're going to find out that you have a slightly more amount of fluoride in the product than you do in their competitor. And that's just the biggest reason, the difference in the cost and what you'll be paying. As far as the mechanism of action, this is a review paper on silver diamine fluoride, and it reviews the mechanisms of action that these products have. It's not completely understood yet, but we know the fluoride acts on tooth structure, and our silver ions act on microbes or strep mutans. When these products works, they alter the hydrogen bonding of the microbes, inhibit the cells from dividing and duplicating, which is great to prevent the replication, trying to prevent the growth and acidic attack on a tooth. They'll unwind the DNA of the cells, which is beneficial as interrupting their division well. The cell division can be impacted by the silver products, and it also interferes with the cell wall synthesis, what protects the microbe. So if we can impact all these, that can be a huge benefit. If we look at basic silver nitrate and fluoride, when we're doing that, we're combining the two concepts we talked about, the fluoride on the tooth and the silver and nitrate on the bacteria. When you use a product such as silver fluoride or silver diamine fluoride, you're combining both into one and not having to use combine different products. You can use both and have the same benefits that you'd get with A and B. I want to caution you, this was my biggest frustration when I've got Rivastar. Incorrect application of Rivastar will cause black stain. You have to apply it for 9 seconds. And it will still darken the tooth, but it's more aesthetic than if you don't. So correct application on a young child, maybe a 2 or 1 year old or 2-year-old, may be very difficult when you're treating multiple sites. So you may not want to do all the 2-in-1 visit if this is what you're going to want to do, and the parents really want to avoid the staining. If you're just planning on going ahead and just accepting the staining, just apply the step 1 and move on and accept the staining that you're going to come back and fix it at a later date, or try to arrest the tooth so it will fall out. So this was my first attempt here, and incorrect application will cause staining. I did this just extracted tooth, and I did a time-lapse video, and this is what I got. I got acceptable results for an aesthetic outcome. Yeah, it may be arrested, but it doesn't look very. So I took another shot at it, and I thought, oh, well, I'll go read the IFU. So I never read as dentist, and I read the IFU, and it said to apply it for 90 seconds. So I did it. And here's our next slide. Here's our video. Lapse here overnight of the original Rivastar and Advantage Rest. And I've seen the same outcomes with my patients in aesthetics with the Riva Aqua. And I think we can all appreciate that it did darken the Riva. I will be honest with you there, but we also did get a more aesthetic outcome if we're trying to be mindful of that with our patients. If if the parents don't care and they accept the darker stain, then by all means move forward with that and don't spend that 90 seconds, especially if the kid's not cooperative. So here we have the difference in the two. I'll come back to this. Jeff Knight, who was big in developing this, here he did a tooth that he stored in water and direct, and we know that light changes silver diamine fluoride to a silver oxide. And here you can see 6 weeks later, we have got a more aesthetic outcome. And I want to show you how you can obtain that on permanent today as well. If we look at the AAPD guidelines, we find out that SDF is more desirable to some patients compared to sedation and anesthesia. I've had multiple people come to my office and say they don't want sedation or anesthesia for their child. And this is just another tool to have to be able to work with them, especially in situations where you can avoid it or say things until their child becomes more cooperative or older. It can be a huge benefit to your practice. We know that it works 47 to 90% after one application, and that reapplication may be necessary. This is a child that I put silver fluoride on these occlusal lesions because I didn't have bite wings. And you can see there's nice rested areas there on the second primary molar, but we still have some active lesions here on the first primary molar. So we know that reapplication may be necessary, and we also know it's more effective than fluoride varnish every 3 months, which I do for a lot of my patients. And I'll go over this later, but addressing other caries factors is important. We all know these kids are having these gummy vitamins, these sticky snacks, crackers, chips, goldfish, and it's just sitting there all day. They don't pick it out like we do. So put your patient on a 3-month recall. You do that for periodontal disease. Why not for caries management in kids? That's what I do at my office. We have a high-risk kid and we're working with them and we're using diamine fluoride. We're going to put them on this 3-month protocol, and then we're going to work on something each to come. So maybe the first time they come, we want to address their gummy vitamin or what they're having, encourage them to get that out. And the next time they come, we want to address their brushing habits. If you see them often for the problem, you're more likely to see where they are in the motivational of buying in. And some people, it's okay. Some people may not want to fix the problem, but we want to do our best as providers to do everything we can for the kid. They don't buy the groceries, and it's nice to be able to have something that you can rely on to be able to deliver the quality care that you'd like to at your office. If we look at potassium iodide and Revastar, you can see that this works. This is the antimicrobial effect. This is a petri dish with they tested against different bacteria, and here you can see a reduction in the amount of bacteria that are present in the large inhibition zone on these. So that's a great benefit to using the silver diamine fluoride and potassium iodide together. You can also see a nice penetration of silver. We're going to see that silver penetrates deeper into the lesion with just silver fluoride alone. And if you add the potassium iodide, it's going to be less, but you'll get more penetration of the fluoride. Typically, in the studies that have been done on the silver fluoride and the potassium iodide, it's going to go 50 microns. So if you have adequate remaining dentin thickness, you are definitely be safe in placing this in a lesion that you're doing indirect pulp therapy on. Primary teeth, you need 1 millimeter. Permanent teeth, you need 0.5 millimeter. And you're nowhere near the 50 microns from where that's going. So you're not going to cause pulpitis with this. If you also look at the amount of silver, this is what I just spoke on, or the amount of fluoride, I'm sorry. The fluoride deposits here with deeper, it's almost twice as much fluoride into the dentin if you do the second step. So consider that. We'll talk a little bit about effectiveness of both and see what you want to do at your office, because there is definitely a compromise when you look at aesthetics versus arrest rates and what you need to look for at your office. And I'm going to show you exactly how to do that today with glass ionomer. When we look at root caries and SDF versus silver fluoride and potassium iodide, they're both very similar arrest rates at 30 months. And we also see the similar discoloration at 30 months. And this might be, maybe, I don't know, the study didn't give us the protocol on how long they're applying it, but if you don't apply the potassium iodide for 90 seconds, you're going, like I just showed you in experience, you're going to get the staining. So that may be a difference in why the study had arrest rates and also discoloration. If we look at the AAPD guidelines on the studies that they have picked out for silver diamine fluoride, this is not silver fluoride, to be clear. At 24 months, there were 2 studies. They had a 68% arrest rate. Over 24 months, randomized controlled trials and a systematic review of them. 3 studies, and they had a 72% arrest rate. So these are very good numbers if we're looking at kids that may cooperate and we need to get a little bit more time. If you look at over 30 months, there are 2 studies, and they had a 76% arrest rate. And then another one at 24, we can get to an 87% arrest rate. We also found out that all these studies that 1 application is not as good as 2, and 2 is not as good as 3. I'll settle for 2 at my office, and I'll show you why here in a little bit. If we look at the study that SDI is touting for the Vistar Aqua, this is a study that it's got a few issues when we look at it from an Americanist standpoint, from radiographs that I want to cover. And some of the conclusions are, the study's not comparing apples to apples, and I'll show you. If we look at this SDF and just step 1, the silver fluoride, this was Rivistar used to study. We've got similar arrest rates when we don't include the potassium iodide, about 75%. When you add that second step, you're going to go down a little bit with the potassium iodide at 12 months. At 6 months, it's actually higher, but at 12, it did drop, and it dropped about 25%. So keep that in mind. When we use the second step of potassium iodide, we're trading off aesthetics for a higher arrest rate, and that is okay. I would rather have a higher aesthetic outcome on an anterior tooth if I need to, and a higher arrest rate on a posterior tooth. So you combine using step 1 alone, or you can use step 1 and 2, depending on the situation you're in. We all have different materials. You wouldn't use amalgam on a front tooth, but you might use amalgam on a posterior tooth. And that can be something that can be beneficial for you to understand. You don't have to always do the second step. You got to pick your battles, especially sometimes with kids. If we look at potassium iodide at 12 months, like I said, quarter less arrest rate. And that's okay. If I want to treat a tooth in the anterior region, and I know that, I'm going to have to see that kid every 3 months and keep a closer eye on it. If I want to use, they were 6 times more likely to not cause discoloration on teeth. So that's a huge advantage. So 6 times more likely not to stain the tooth, and 25% chance to arrest the decay. So you can definitely do this in your office and be successful with it. And I would say this was a kind of a frustration of mine with this, is they had higher rates of pulpally involved lesions with the KI group. And so let's dive into that a little bit more. Here I've just highlighted a few. Group 4, which was the silver fluoride and the potassium iodide, had a higher proportion of ICD-10 codes 3 and 4 lesions. So they had more large lesions, and the biomechanical properties, these lesions would break down over time more likely. This is why it's not apples to apples, is because you can't look at a group of women that has more lesions that are larger and compare it to a group that has fewer. If we look at the historic endodontic literature, this is a study, this is way back. This is a key study in the endodontic literature. If we look at chronic inflammation of premolars that are extracted for orthodontic reasons with enamel caries, 50 of the teeth that were extracted had inflamed pulps. 39 exhibited an impaired odontogenic layer. And that's just a carious lesion in enamel. So I would argue, which came first, the pulpitis or the treatment? And I'll tell you why I think the study had its impact. Here you can see, this is from my dad, Dr. William Johnson. Here you can see change in the odontoblasts layer, chronic inflammation in a tooth with enamel caries. And it doesn't have to be that far in to cause a change. And that's good. We want the body to respond and lay down more enamel and dentin, but we can't say pulpitis occurred because we just saw it visually. So it's really a problem with the definition of pulp involvement. There were no radiographs utilized in the diagnosis, and I would not be treating a tear without a radiograph in a manner that is set to be definitive. I might do it temporarily, but if you asked a oral surgeon, would they take out a tooth with a radiograph, they would laugh at you. Pulpal involvement was evaluated in the PUFA index. So if it was pulpally involved, that means they could see the pulp, I guess. Also, if it's sharp and it's cutting another area, fistula or a chronic apical abscess, and an abscess. And this was a visual index. This had no radiographs. So how do we, I would never make a pulpal and periapical diagnosis without a radiograph. So how are we relying on this assessment to make those? And does potassium iodide cause pulpitis? Unlikely. My guess is the higher rates of visual progression are likely due to the arrest rate. So if we look at the study, you have more teeth with larger lesions, and you have teeth that have a 25% more chance to continue growing. So how can we turn this and be successful using aesthetics? Well, it's using a glass ionomer as a smart technique over this. With the glass ionomer, I use Riva Self-Cure H in my office. You're going to form a chemical bond to an amine adentin. You're going to release fluoride. It's very biocompatible. Coefficient, this is big. Coefficient of thermal expansion is closest to dentin. So when you have a hot or cold sensitive patient, this as a base or liner is going to make it that expands and has less issues with the degradation of moving fluids through the dentin tubules. It also requires moisture. That's very beneficial to us as pediatric dentists. We're treating a kid knee to knee. It can have a huge impact on the material selection. If they're wiggly and you just need to get in and get out, it's going to set up and work very well at your office. The great marginal sealing also here you can see a dye-leach study compared to flowable composite. Composite shrinks. Glass ionomer has a chemical bond to the tooth. And if you look at it, even this, and I didn't include the slide, but underneath the microscope, you can see a huge difference. We also see that there's cumulative fluoride release. So if they're high caries risk and you can take a 6-year-old and put them on fluoride toothpaste, that can be a benefit, even if they're only using that toothpaste once. We find studies that kids that are put on like a Prevident toothpaste, actually, if they're not brushing, they get more benefit than the kids that are actually brushing. And that's because they have the higher fluoride and they're removing the biofilm more in a way that than they used to. So it's a big benefit. You can also look at acid erosion. I know there's a debate, do glass ionomers wear? Do they have acid erosion? Well, they do both. Low acid erosion for Riva Self-Cure. And when we look at wear, surface hardness is huge. We know the studies that look at glass ionomer wear over time in the lab have human teeth that they'll demineralize and then bond to and then wear over time. And we do wear, but after a year, we're seeing stronger material than we are in the initial set. And I think that's why I think glass ionomers wear in the first time we place them rather than later in time. And you can see these kind of stabilize over time at your office. We look at bond strength. There's a lot of people say, well, what does it do to composite bond strength? Well, we have a systematic review with 13 studies, and they reported a wide variation. So we had anything from less than 10 megapascals to 162 megapascals with composite. 4 studies found a decrease in bond strength with composite, and 4 studies found no change. So the jury's still out there on this. There's no conclusion that they could make on the bond strength to adhesives, but we do know that glass ionomers and these of a product like Rivastar can increase the bond strength of glass ionomer. We can say that with certainty. We also know glass ionomers have limitations. This is a larger lesion on a permanent tooth, and it's a stress-sparing area. This is, not ideal. It may be something you choose for a high-risk patient, but you got to understand the limitations of the materials. We just can't use it in every situation. So what patients can benefit? It'd be like an infant with severe early childhood caries where they have caries on their anterior teeth. And I don't want to put a kid to sleep for just 4 teeth if we can avoid it. Children, we know they can be unpredictable. Maybe you have a kid that you think will do well for an operative appointment. It's going south and you want to switch things up. We've all had this grumpy teenage in our chair where they're just crossing their arms and they're not going to do that because they don't want to that day. And this may be a way you can work with your patients and bond with and benefit with them. Adults could benefit that are in pain with the reversible bulbitis if you don't have to treat them. Older patients that may have dementia are definitely a candidate for using a smart technique. And patients that don't have large lesions with special healthcare needs, it may be best to try to delay things until they either have more needs or we can avoid that by invasive treatment by working with them. High caries patients could benefit. This one I probably would not be too excited about using SDF, and with all the demineralization, we'd have potential for auto staining. You have to be very careful in this patient. And then lesions too difficult to treat. This is one that came to my office with a large lesion on tooth number 30, and she was in pain, and I didn't have time to treat her with the limitations on aerosol procedures. So we went and did a smart technique and got her out of pain, and she came back and we finished our routine restorative. Uncooperative patients with small lesions, perfect way to use this. Great service to them. If they don't have to go to the OR or get sedated, I'd rather not. Erupting teeth, you can see a carious lesion on the buccal pit of number 19. That's going to be a challenge to restore. Hypoplastic teeth, these kids are often hard to get numb, and using SDF can desensitize them and provide a great service to them. Teeth near exfoliation are beneficial as well. This I probably wouldn't want to extract if I didn't have to, and I probably wouldn't want to throw a lot of money into it as a parent if it's going to fall out within a year. So that may be a benefit. Patients who don't have access to care. This study that I showed you out of Cambodia that we discussed was that they're just trying to manage the caries of these patients. I use this a lot. Patients that are waiting for sedation in my office, we'll do the SDF and the interim therapeutic restoration to try to get them. I don't like emergency calls, and I don't want to have to deal with it if I don't have to. And also, if they have dentin hypersensitivity, this can definitely be used. It's what it's approved for. And there's almost a situation where I could see everyone benefiting from it in a certain situation. So a few considerations here that I want to share with you. You're more likely to arrest the buccal or lingual tooth than interproximal 15 times, and you're more likely to arrest an anterior versus posterior tooth. And the difference basically comes down to anatomy. Anterior teeth have smooth surface decay and interproximal. Posterior teeth have pit and fissures and interproximal decay as well, and that's where stuff gets stuck. I think this is the biggest thing that I preach at my office is diet. You have these eating cookies, dried fruit, crackers, chips, cereal, fruit snacks. This is a poster we have at my office, and it sits in their teeth after they eat it. If they don't get that cleaned out, you have fermentable carbohydrates sitting there all day. And we know that sugars and fermentable carbohydrates are a key in providing tooth demineralization. The last in 2021, the JADA cover was on greater compliance with their dietary measures is associated with lower prevalence of the odd of untreated caries in adults. And it's the same for kids. It's often overlooked at us, and it's as important as brushing your teeth. You can brush 3 times a day, but if you're eating junk all day, it ain't going to matter because what's sitting on your teeth don't have time to recover. I love the book by Dr. Roger Lucas. I had a pleasure meeting him at the APD in Washington. He's got a great snack guide. Check out his podcast with Howard Fran or read his book. Highly recommend it. We give everyone a snack guide at my office and also that list. If we move into looking at cases, we talked about posting. I'm a bigger fan of doing a Hall crown on these 2 teeth here on T and S than doing SDF. And that's because of the posterior being less likely to arrest. So obviously, if a parent wants a more aesthetic outcome, a smart restoration, the benefit here. But here, this patient just came into my office recently. High risk. Here we're seeing new decay on K and L. But this kid, 3-year recall, just Hall crowns, no drilling on the tooth, no nothing. And very successful outcome, even on a lesion on number K. So keep that in mind. Posterior teeth, that's why I tend to lean more to Hall crown unless they're uncooperative, if we've got x-rays. So keep that in mind. It's definitely a tool, but there are other tools, and conventional dentistry is great as well too. I won't bash any of that. Can patients benefit from SDF and glass ionomers? Definitely. We use it at my office as a diagnostic aid. If we've got incipient decay, we like to apply it there. There's a new group for sealants you might be interested in. We can use it for palliative care. Patients with a lot of lesions can't treat. Patients with reversible pulpitis that come in that I don't have time to treat. And then like I talked about with sedation and anesthesia, you could use it for dentin hypersensitivity, improve access to care for pediatric patients. I don't treat geriatric patients, but they could benefit as well. Patients with special healthcare needs, it can be a huge benefit for. Love the SMART technique, and I love pulp therapy. Every patient needs to be treated toward their individual needs. There's not one way you can't just put a blanket on and say, I'm going to use SDF on everything. It's not every day to use it. It's a lot of days, but it's not every day. We have kids with issues to access to care, and if they get back into my office, it may be beneficial to put it on and try to delay things until I can get back. If someone has cancer and they've got pulpily involved lesions, I'm not going to mess around with this when they're going through chemotherapy and immune compromise. We're going to be definitive. You may want to use it on some kids that are like this, where they're hugging the mom's leg and you can see a cavity. Don't think it's large enough into the pulp. They won't get x-rays. A perfect solution to do that and put them on a 3-month recall. I don't want to put a kid with 8 class 2s to sleep and have to. So judging the risk of sedation versus urgency of treatment, that may be something we can work with more often every 3 months. Parental desires. Maybe some kids and maybe the parents don't want to put the kid to sleep. And this could be a tool in certain situations, not everyone, you could use to benefit them. And then obviously this patient has very acute needs and would not be one that I want to wait on with this. So keep that in mind. It's not a candidate for everyone. You just got to individualize it to your patients and use your best judgment on what you can get through with. If we look at what I do with my high caries risk patients in cooperative, I'll do 2 applications of SDF 2 weeks apart. And then once I see lesions arrested, I'll put a glass ionomer over it. And this is what changes the food intake I just showed you and makes it more successful. If we get them to have things in there, they're not getting food stuck in there, the cavity, if you don't eat, you die. And if you can seal off that lesion from growing, you're going to have a great benefit for your patient. And sometimes you'll be able to restore these, conventionally. And if things aren't progressing well, you may have to go ahead and use sedation or change up the protocol that you're using and switch to just using the silver fluoride alone. I typically will do the smart technique on every tooth that I can. If it's got an area that I can put glass ionomer into tooth, I will do it because I know that's going to prevent the food infection. I'm going to skip over the billing codes here. If you want to take a screenshot of that, these are what I use. Typically, we'll do the caries arresting medicament per tooth. And then if it's something I'm planning on redoing, either an ITR, interim therapeutic restoration, or a protective restoration for the kid. I'm going to skip through that video just in lieu of time here. I know we're getting close to be able to answer some questions. It's just a kid that was waiting for general anesthesia. And we just did SDF on their teeth. And here I was able to restore them with a nice outcome, Spriggs zirconia crowns. I was fully intending on restoring those, felt delay things because I had a few months wait. And it could be longer. Here's before and after. We were able to cover up that stain and have a nice aesthetic outcome. I want to move through some cases with you. This is Harrison. He was complaining of toothache. We don't know when it was heating or hurting. He's had pain and mastication. It's been localized to a certain area, and we don't have a great history of, and it is if it's short or prolonged. He's seen a general dentist for pain, referred to your office. When he asks him about pain, he points to LNS. He's pretty cooperative, will chair and have a conversation with you without being too stressed. This is what was sent from the general dentist. We obviously have a little more information we can't see the furcation of these teeth, so we need to redo x-rays. So after evaluating the x-rays here, we have tooth number S, looks like the furcation is well involved. And number L here, we can see a darkness, but not necessarily a blown out furcation C. So in this case, we use SDF to get a diagnosis. We did all the history and information we wanted, and we went ahead and applied SDF to the teeth. The kid, we had them call back the next day. They're still experiencing pain, and we went and diagnosed one of the teeth here, L with necrosis with SAE and plan for extraction, and the same thing with S for irreversible pulpitis and extraction with a loop. So I didn't expect this, but this is my importance of using a barrier. The incipient lesions on the other teeth when he came back for his banded loop. So the SDF actually etched out. So be very careful where you're placing this. If you're going to have an anterior region, you need to go ahead and put a fluoride varnish over the tooth or Vaseline before. Serenity here, a chief complaint was she has cavities, ASA2 with asthma, no issues with pain that we're aware of at the time. She's seen a general dentist for evaluation and referred treatment. She's not as cooperating with her asthma, not a candidate for oral sedation at the office. So here we see deep lesions here. Let's focus down in on K and L. And a comprehensive exam, she has other caries apparent, but here we can see we don't have any symptoms and we have inadequate remaining dentin thickness on number K. So we want to use caries removal for diagnosis, and then we're going to determine if the pulp's bleeding a lot. We're going to go with the irreversible pulpitis. If we can control it, we may do a pulpotomy. Our options were this is not the case that I would treat with minimally invasive dentistry, given the extent of the needs. And that's important to know that we may need to do more advanced things at certain times. This is Alexa. She's an anesthesiologist child, and she had pain to biting with mastication. It was spontaneous and localized and prolonged. And here you can see a deep carious lesion on L, and that was the culprit. This is the best x-ray we could get. One of the most probably nerve-wracking oral sedations that I had in my life. And she said, well, it's okay because I'm here. She hasn't eaten. Let's go with it. So we did the same day oral sedation. Back when I started my practice, I had time. Bite wings during the sedation, removed L and did a hollow crown on K. Here's what we knew. We had somewhere to K. We knew it was small. I offered to, take her to the hospital, fix everything the normal way, or do hollow crowns. And she did her research and she chose to do hollow crowns, even though she puts people to sleep for a living. So here she is coming on her recalls. I worked with her every 3 months, and we were eventually to the point where things got a little bit bigger, we got more aggressive. You can see we did some crowns and fillings, and here we had a nice that she was able to build trust with us, and we used a combination of both things, SDF and Hall crown, everything, soup to nuts. This is another patient. This is Lily having thermal stenosis, a localized area. Here you can see anterior teeth that there's not much left of, and posterior decay. We can handle this, extracting D, E, F, and G in the office and doing minimally invasive dentistry on the posterior teeth. The parents did not want sedation for this kid, and she's now one of my best patients. First visit, we extracted D, E, F, and G, and then we did our Hall crowns. And this is her after getting the Hall crowns done. She was screaming, needed a knee in my lap. I didn't torment her with this minimally invasive dentistry, but it's kind of a fun video. So that is not the kid that you've had in the papoose board that's been held down. That's a kid leaving the office. So keep that in mind. This minimally invasive stuff, it can work, and you just got to find out what combination is going to work for you. When we look at the Hall technique versus non-operative caries treatment, or just removing areas of food impaction and fluoride treatments versus conventional restoration, this is a 1-year study from the other pond. Hall technique, 98% effective, making it so food stuck and applying fluoride 75%, and doing our conventional restorations only 71%. So I'd like to see where this goes, but just kind of astounding how doing something minimal for the patient can be maybe the best thing that you can have for them. I'm going to skip through a few cases here, and I want to get to indirect pulp therapy and the SMART technique. We will do this one here. Actually, to start. So this patient here has a deeper carious lesion, and maybe they're not cooperative for you. This might be something you can do with the SMART technique. So if you look at, this is a patient with a hypoplastic mold, teeth are erupting. We went ahead and she was not cooperative at all. We applied SDF, and then SDF again in 2 weeks, and then placed glass ionomy. We stabilized her and stopped the lesions from growing. She came in every 3 months, her behavior back on board, and we were able to eventually restore both these with stainless steel crowns, prevent her lesions from growing. And that's just a great, successful outcome to be able to save this young lady's, permanent first molars. So just one way you can use it. Here's the other side. Everything stabilized, and we finally got to the point where I could treat her without sedation. And I think it went. Here's a tooth I showed you earlier. Same thing. Here, stabilize the lesion with SDF, and then we're able to restore the tooth at a later date. I'm going to move on here, and we're going to go skip a few things here with these cases in lieu of time. And we're going to move on to indirect pulp therapy with the SMART technique in aesthetic outcome. This is a patient that came to me, very uncooperative, deep carious lesion here on his permanent molar. And I just want to share with you the SMART technique here. I'll let this play, and then we're pretty close to getting to the point to answer any questions that may have arisen. We're nearing to the end. So this is also available on YouTube if you need to look at it again as well. So here we are with deep carious lesion here on a permanent molar, and it's positive for pulpitis. Avoid pulp exposure here, and I'll let this play.
Indirect Pulp Cap Protocol by Jared W. Johnson, DDS. Begin by accessing the cavity. Throughout the preparation, an explorer can be used to detect soft carious dentin. Remove all soft carious dentin tooth-dentin enamel junction. After the final preparation is completed, etch the tooth in preparation for the Riva Star application. Thoroughly dry the tooth and apply the Riva Star Step 1 for 60 seconds. Immediately after the application of Step 1, apply Riva Star Step 2. It is important to apply Riva Star Step 2 for the minimum of 90 seconds. Also, make note to apply the step to any other surfaces of the tooth with a white spot lesion, as these can be stained by the silver diamine fluoride. After the application of Step 2, thoroughly rinse and dry the tooth. A high viscosity glass ionomer such as Riva Self-Cure HV can then be applied to the preparation. While the glass ionomer is setting, apply Riva Bond LC and light cure per the manufacturer's recommendation. The tooth can then be restored with a composite resin of your choice. Here is tooth number 18, 2 weeks after treatment, showing an aesthetic outcome.
So again, we're not getting the darkness or black staining, even with the use of a curing light, with using the glass ionomer. You don't have to use a Riva Bond LC. That's just a glass ionomer bonding agent. You can use, if you let the Riva Self-Cure set up, you can use whatever bonding agent you want. Just wait the 2 to 3 minutes it's just set up. This is going to be the same with the new Riva Star Aqua. This is tooth on the other side that I treated with the original Riva Star, just using a resin modified glass or Riva Light Cure HV, doing a bulk fill with it. And here you can see, even on the white spot mesial, we didn't get that staining that I showed you earlier. And you can have the same exact outcome with Riva Star Aqua. If you want to check out an article on the same thing that we just did, use step by step, the Riva Star Aqua, I showed you the video. It's the same procedure. If you want to use your own different bonding agent, you can use a different glass ionomer if you want. I really like Riva Self-Cure HV because, like as you saw in that video, it doesn't stick to your instrument and you don't get plaque. And that's a big complaint, the sticky situation with glass ionomers. I want to finish with why to use SDF and why silver products have become so popular. It's because the parent sales these days. everyone wants their child to create their own experiences. They don't want to make them do anything. It's like when you have the kid come in for the knee to knee exam and the parent will lean them back because they're crying. They don't want to make them do it, even though it's necessary for their oral health. And we also have every kid getting a trophy for everything. And life's not that way. Life's tough. And if you're raised in an area where you don't deal with hardship, failure, you don't grow. And I've learned so much more from my failure. So kids need to fail to a certain extent, but within the boundaries of norm, and be put in a position where they can learn from it and improve and be coached into a person that is going to recover from that failure, realize what they did wrong, and then move forward and make a better decision the next time. We also have so many kids out there in poverty. We have the 80-20 rule. So we have 80% of the K and 20% of kids. I see 60% of kids on Medicaid at my office. And some people come 3 to 4 hours to see me, and reimbursement's low. And these kids, that some of them can't afford to get to us. And if we could just have more providers embrace things like the hall technique on smaller things. Imagine a kid that was referred to me and they couldn't make it at that time due to finances. And now they're 6 months in, and it would have been a candidate for a hall technique or SDF and a GI. And now they couldn't get, that was not discussed about what they could afford to do as a family. And now the problems become worse, need a phlebotomy or an extraction. There's so many ways we can use this. We employ this. I would love to see more community health centers employing these techniques and really maximizing what they can do for this at-risk population. It's truly my passion. We have kids that I've been seeing for years that drive 3 hours and they won't go anywhere else because they love it. And it makes me feel good, but it also makes me so happy for that child that we were able to service them in a way that was compassionate. We also have issues and concerns regarding sedation and anesthesia. Megan Kelly, I think 3 years ago now, was on NBC talking about children at risk at the dentist. We had our AAPD guidelines change with our sedation laws, and it's been a big concern of the public. I believe sedation is safe, but I think we should use it just like SDF in the right situation. And I will say, I have plenty of kids that go to the operating room, and it's like this case. This is not a case where I would use SDF. Maybe I would before they go to delay things, but it's not going to be a case where we have adequate remaining dentin thickness on especially A and K to be able to treat them in a conservative manner. It's just not appropriate at my office. So knowing when to use it and how to use it and how to be successful is very, very important. And I will say, SDF is just another tool, and it takes a really, really skilled provider with diagnosis on knowing when and how to use it. It's like the saying goes, if all you have is a hammer as a tool, everything looks like a nail. And SDF is very useful, but if you were a dentist trying to screw this nail in with that drill bit, I'd have a challenging time. And you need to understand when you can use it, when it's appropriate, and also understand what other options there are for the child and what's going to be best in their interest with the financial situation and home life. So pleasure with you all. I'd encourage you, if you want to follow me on Instagram, I do post some dental tips. I'm a 10th District ADA member and ADA New Dentist Committee member, and I post things with the ADA and just tips related to dentistry. If you want to follow on Instagram at jared.j, would love that. Would love to hear some more things from you. If you want to email me, drjared@arcticdental.com. Don't forget there's 2 C's in Arctic. And we'll turn this back over here to start with questions. I'm going to switch here over to the questions. If you have any questions, please ask them at this time. I will read them out and then get back to you. So our first question here, great question. Can you use SDF or silver fluoride permanent teeth? And how do you eliminate the black stain? So yes, you can use SDF on teeth. It's a great resource for kids that are uncooperative or maybe geriatric patients. And the black stain comes from the silver forming into silver oxide. So if we look at that, the potassium iodide is going to be able to combat that and eliminate the black stain. So you need to apply the potassium iodide with Rivastar for at least 90 seconds after you go ahead and apply the SDF. So SDF is recommended applied for 1 minute, potassium iodide 90 seconds, immediately rinse and dry, and then you're good to go with your restoration if you would like. Let's see what other questions we have. These are great questions. Thanks for using it. About the patient that was in pain, can we use SDF in cases with irreversible uveitis? If yes, could you explain a little bit? My answer is no. So you can use it to diagnose it. That was a situation. You may have these at your office where you have a parent come in or a grandparent come in for say, and they have no history of when the tooth hurts at work, and they don't know where the tooth hurts, when it hurts, if it was hot or cold, if it's spontaneous, if it was to mastication, and you have really no clue. It's a lesion, you don't have radiographic signs. We had one on one tooth, not on the other, and you can use it as a dentin hypersensitivity treatment. Go ahead and put that on the tooth, and if you even want the glass element, and then just see, tell the patient, I'm not sure what's going on here, but I would rather not put that child through a procedure, especially at a young age. They don't need to go through one that's unnecessary. So I would rather be definitive in my diagnosis before I treat the tooth. And we find out that if we're using even just glass eye without SDF, but I'd use both if you're in this situation, that if you do that in months later, if you're uncertain, you will find out on the x-ray. You'll have a great success. I think it was Cole had the research on that. Okay, next question here is why etch before using So if you want to go ahead and use etch, it'll open up the dentin tubules before that. And then the silver diamine fluoride or the silver fluoride will have a easier way to penetrate into the tubules, so you get deeper penetration. So that's why the recommendation is to etch. If the kid's not cooperative and they're just sitting there knee to knee with me, I do etch. It's for when I do indirect pulp therapy and I'm confident I have 0.5 millimeter in permanent tooth of remaining dentin thickness and 1 millimeter in primary teeth. Then if they're cooperative, go ahead and do your etch, SDF, and then your restorative procedure. Okay, that wasn't a question, but thanks for the comments. Been in general practice since '85. A couple of my classmates, awesome friends that do pedo. I still don't know how you guys do it every day. But every day is different. That's what's exciting. So it's fun to talk to the kids. You have to follow me on Instagram. There's a kid that asked me if I like beer, so go look for that answer. How do you treat a class 2 cavity that has a CEJ lesion with SDF? So if we're getting that far down on everything, the Riva Aqua is going to be very friendly to you, and using, whatever isolation you choose, but you can also do the Riva Aqua and then place a glass ionomer and do like an open sandwich technique where you raise the box up. So if you do that, you're definitely going to have a material that can be more moisture tolerant, or amalgam. You could use that too, but I would probably doing composite restoration. I'd go ahead and do glass ionomer, which is more moisture, get as dry as I could, raise the box, and then go ahead and replace my band, whatever matrix I wanted to go ahead and restore the tooth. Could I describe my protocol for the Hall technique? Do I use SDF prior to crown placement? I do sometimes, yes, absolutely. If I'm not sure of the diagnosis, I will definitely place SDF twice, once, and then put a glass ionomer in, and then have them back in 3 months for an x-ray. We find out that in 8 weeks, usually if the tooth is dying, we'll have pathosis on the x-ray. My protocol, I used to place separators for everything. So I put orthodontic separator in, mesial distal of the tooth, if I could fit it, have them back in 2 days, take it out, and then it's really easy to get a crown on that way. I found out that a lot of families were traveling 2 hours just to place separators, and I've gotten a lot better at sizing. So now probably 90% I can get on the same day without placing separators. We're talking about costs at our office. Insurance barely covered. How do you explain to the patient? We're a pediatric office. Some parents choose not to do it and leave with it untreated because insurance will not cover it. Well, I think it all relates to your area. So in my area, we do have, I think I get $1.34 from Iowa, and then I can't restore the tooth for a certain period of time. If I look at the cost to me of doing this and having a patient with me a long time and having a better successful outcome, let's say they need sedation, then I'm also looking at time for that outside the office. It's honestly, it's profitable for me it's not very expensive to get this material. It's very, very cheap. And I would say to you, if I do multiple teeth in the mouth, typically I'm a nice guy. I probably am not as nice as I should, but I'm only billing for one application for all the teeth, because I think it could get very expensive with some insurances not covering. If you're charging half your fluoride fee, obviously if you got 8 to treat, that gets expensive, and you may just want to do something more definitive. So I try to make it cost-effective for my patients. If you want to, come up with a fee that's reasonable to cover your SDF price and your glass ionomer and your chair time and your assistant time, and just pitch them to that this is the fee for these 2 visits where you get the 2 SDFs in the application of the GI. And then when you're ready to restore the tooth, the insurance isn't going to say you put a temporary in and now you restored it. So you're going to be able to cash in on that. Just like people say with an immediate denture, you don't want to use this because you want to have the benefit for your final. How do you get insurance to cover 3-month visits? Well, if you're lucky, you'll get a narrative. In Iowa, I'm 55% Medicaid. I get a prophy and a fluoride every 3 months. I'll take that and eat the preventative exam over having a kid end up going to the OR. How successful on interproximal caries? Well, it's 15.6 times likely to be successful on interproximal decay, as stated in the study there. Does the decay arrested by STF need to be restored if not cavitated? I would say it doesn't, but we know from the research that these lesions can start and stop growing. So my idea for you would be able to go ahead and place a glass ionomer over that as a sealant material if you've got incipient decay. If they're not cooperative, I would still go ahead and place a glass ionomer over it just so they're not getting food impacted and you don't have it restart. That's really the key to success with these materials, is going ahead and getting rid of the food impaction. So you can use the silver and the fluoride to treat the lesion and get rid of sensitivity pulp, and then stop it from growing by putting something in there. And that's, I think, why the Hall technique is successful. How much decay do you remove prior to SDF? You don't have to remove any. The AAP guidelines say that. If you're doing indirect pulp therapy, I would just remove what you're comfortable with to the CJ without exposing the pulp, and then go ahead and place the silver fluoride product and the potassium iodide. Can we apply it directly to the caries lesion, or do we need a pumice first? I would recommend you just get a toothbrush, clean it with the toothbrush, and get any food and plaque out of there. Go ahead and apply it. That's going to make it a better product for you. What advantage of Riva Aqua? Advantage of Riva Aqua is, number one, the pH is more physiologic. You're not going to get the soft tissue burn that you get with Riva Star. And also, you're going to limit staining. So if you compare it to what you have with Advantage Arrest, you're going to go ahead and lose some of the caries arrest, but you're doing that with a more aesthetic advantage. So you can treat permanent teeth. You can treat anterior primary teeth, Riva Aqua, and not have a dark tooth. And that is, when I talk to parents at my office about SDF and it potentially staining their front tooth black, case acceptance goes up when you can go ahead and do that without the black staining. If using SDF on a patient when you sometimes will not do a restoration afterwards, if so, does the area show up as a carious lesion radiographically? Yeah, so I skipped going over that just at a little time because I was running short. But yeah, so if a tooth's ready to fall, I was going to show a case today where we have carious lesions as applying SDF to, they're interproximal, they're pressing, but we didn't get new decay on the permanent first molars. We'll often get that when they're kissing lesion. And those are kids that I may not go ahead and put a restoration. If the tooth gets to exfoliation and I just want to slow things down to get by, great service for the kid. I'd rather do that than extraction or a filling and save the patient money. And by means, if you're in that situation, I would, definitely charge your full fee. Use Riva Star underneath the Hall crown. Absolutely. If the kid's not cooperative, I would go ahead and use the Riva Star Aqua. The Riva Star original requires isolation, so you can use it. And I'm excited to see where indirect pulp therapy goes here in the next coming years with calcium silicates such as MTA, Biodentin, and then also the SDF products. Can you use SDF as a diagnostic before a fissure sealant? Absolutely. If you can see if it's demineralized, it will. If it's demineralized at all, like if it's just an incipient lesion, it'll still stain it. But you can definitely see where the caries are. And it's not going to hurt if you want to use it before a sealant, or as there is a new code for caries preventive measure, if you want to use it, Riva Star, and not have stain, and you don't like to do sealants, and some people think they leak and they don't want to do them. And this may be an alternative for them to go ahead and use that. Which is more effective, Advantage or Riva Star on caries lesions? Well, it depends. If you just use step 1 of Riva Star, the study I showed you would indicate that they are equally successful. If you use step 2, you're definitely going to have a lower arrest rate because you're precipitating the silver out as antimicrobial, but you're treating that because the silver causes an anesthetic outcome. So there's a place for all the products here. You got to choose what's going to fit best in your office, but not every parent wants to have a dark stained anterior tooth in their young kid that's starting kindergarten this year. I think we answered quite a bit here. I don't know if there are any more questions coming in or where we're at in the webinar and how timing's going. So I appreciate everyone coming out. If you have any questions, you definitely can email me. I appreciate if you'd follow me too. I'm going to get some tips, see if I like beer. And I think we've got all the questions answered. So I will hang out here. If there's any more that come through, I'll go ahead and answer those as they come in. But again, thanks again. And we'll look forward. Hopefully I get to come back on another webinar here with Viva. It's been a great experience to work with the company. I think they do a great thing for moving dentistry forward in our profession with providing CE to all of you with their sponsors. And it's just a great company that I've had a great experience with.